All right, so we will now be joined by three additional panelists who are going to discuss the legal challenges and considerations for liability protection, particularly physicians, nurses, and EMS paramedics. So first, we have Dr. Robert Anders. He is the administrator for the Alaskan Native Medical Center Tribal Health Consortium. Next is Dr. Doug White. He's the Vice Chair of Critical Care Medicine, the UPMC Endowed Chair for Ethics in Critical Care Medicine, and the Director of the Program on Ethics and Decision Making in Critical Illness at the University of Pittsburgh School of Medicine. And finally, we have Dr. Gutman Cook, who is the co-director of the Health Law and Policy Institute at the University of Houston, and also the Director of Law and Ethics at the University of Chicago. So two different states, at the University of Chicago, McLean Center for Clinical Medical Ethics. Thank you all for joining us. So I'll start by asking each of the panelists just to quickly reflect on the comments from James Hodge, and then we'll open it up for questions from the audience. If you could just maybe give 1 to 2 minutes of your initial thoughts and reflections.
Thank you. This is Bob Anders. I'll go ahead and start. I think James brings up a lot of interesting issues that are also pertinent to Alaska, where in Alaska, both from a regulatory standpoint and from the statutes, currently does not have a public health emergency or crisis standards of care on the books. And so going through that possibilities, as well as the uniqueness of having 3 sovereigns in the state, very strong in tribal governance, state governance, and federal governance, in our relationship as a tribal entity across the state and providing care, I think presented a lot of unique issues as we went through the need here recently across the state to establish crisis standards of care and actually act on those in various facilities across the state.
Dr. White?
Yes, thanks, Dr. Peak, and thanks also, Professor Hodge, for your perspective. I really appreciate it. So I thought what I might do is address the comments, some comments from the perspective of health systems and frontline clinicians regarding their concerns about legal liability from triage. And so over the last 18 months, I've had the opportunity to have conversations with a number of health system leaders about triage, because they've often used as a starting point for their triage policies a model policy that I and colleagues disseminated early in the pandemic. And, I think the most important thing to say about these conversations is that legal liability was not a primary concern for most individuals that I interacted with, but it did come up as a secondary concern. And that sort of the nature of the concerns that were most often raised were really along the lines of, can we be sued if we follow triage guidelines that the state government promulgates when the result is denying needed ICU care or a ventilator to a patient in need in order to achieve the goals of the state's triage policy? So that's sort of number one, is this broad notion of, can I be sued? Am I protected? And then the second point that I heard a bit even more strongly is this concerns around what I will call re-triage, or this notion of actually not just withholding life support, but withdrawing life support from a patient with a very poor prognosis when there are other patients in need of that resource who have a much better chance of survival. And so, what troubled me most about these conversations is that the health system leaders often expressed a sentiment that conducting ethical triage seems more legally risky than abandoning triage entirely and simply using what I'll call a first come, first serve approach, and pairing that with adopting a stance that once a patient receives an ICU bed or a ventilator, that it won't be withdrawn against their wishes, regardless of whether there are patients who are much more likely to benefit. And obviously this is a concern, because if this stance were taken during times of scarcity, many more lives would be needlessly lost than if ethical triage were undertaken. And so I would just sort of point out from the perspective of health systems and frontline clinicians that to avoid this sort of perverse disincentive against ethical triage, I think there's real value in following the lead of states like Maryland that have enacted statutes that pretty narrowly immunize clinicians, but immunize them nonetheless from civil and criminal liability for triage decisions that are really made in accord with state-approved triage protocols. So I'll stop there. Thanks so much.
That is such a rich discussion that I want to come back to. Dr. Cook, I'll let you weigh in, and then we'll.
Thank you. Absolutely, this is so fascinating. Thank you, Professor Hodge and everyone else for their comments thus far. What I think is so interesting is during the peak of the, I don't want to say peak of the pandemic, but while we were seeing all these laws really start to be passed and take effect, we had at least 37 states that passed immunity protections for healthcare providers. And there was a vast, enormous amount of variation across jurisdictions about what was protected and what was not. Despite this, we don't actually have a lot, or maybe really any, empirical evidence that these immunity protections are actually going to encourage adherence to crisis standards of care, which is often offered as the argument in support of these immunity protections. And so while we hear a lot of anecdotal stories about physicians and other healthcare providers saying that they are concerned, what if, right? Those what if questions, it isn't entirely clear that there is that connection between these immunity protections and adherence to crisis standards of care. And so through my research, I've kind of concluded that despite this huge variation in immunity protections, that really they're only called for in very particular circumstances. The first is where jurisdictions, whether those are state, federal, or local governments, or perhaps even professional societies, have promulgated crisis standards of care that require the modification to the existing standard of care during the state of emergency. And there's actually an identified need to extend legal protections to providers or perhaps institutions based on their perceived reluctance to follow those crisis standards of care in order to presumably save the most lives.
All of that is fascinating. So it feels like we have some gaps between theory and practice, between what people are imagining might happen, thinking about what might happen, and some inertia between what we've done as a healthcare institution and healthcare practices, and some fear from shying away from that in a way that would ultimately harm patients. And so I think it's, so what do we do? What do we do to try and move this forward? What do you all think?
Dr. Peak, I'll offer at least a brief comment, because what Valerie said was very interesting to me.
Mm-hmm.
You know, from the earliest days in which we kind of conceptualized the need for some liability protections, way back when in 2009, when we kind of instituted CSC, we looked at that exact question on the committee. And I remember that because, we saw a little bit of paucity of evidence in relation to what Valerie's talking about. But you know what we did find, and it's definitive, and there's multiple studies to this effect, which is willingness to actually serve in these emergencies. Not willingness to, implement CSC. That's a unstudied issue for sure, Valerie, I agree. Willingness to serve as a healthcare worker, definitively tied through research we see to liability protections that make sure I'm not the next poster case of a healthcare worker that got caught up in this horrendous series of triage decisions that have to be made. We've seen that evidence. It's very strong, actually. And to be sure, I would at least laudably say that's what supports a lot of what you see at the federal, state, and local levels on those specific specific liability protections.
Mm-hmm. Mm-hmm.
Mm-hmm. So I would, as a clinician and ethicist and not lawyer, I would be especially interested in sort of the advice that you might, Professor Cook and Hodge, the advice that you might give to frontline doctors who say, and policymakers who say, listen, on the one hand, clinicians need some protection for decisions that they make that are in accord with vetted, authoritative, legitimate triage guidelines. But on the other hand, overly broad immunity can be a real concern for patient rights and patients' ability to avail themselves of legal remedies if there is really severe malpractice unrelated to triage that happens in a hospital. And I'm thinking of, I think you guys will know the legal aspects better, but Florida has very, very broad immunity protections for anything related to COVID, as I understand it, such that plaintiffs would have to prove gross negligence for any malpractice claim that they brought. And to me, that seems like it has not quite struck the right balance between clinician protection and patient protection.
Great points, Doug. I'll be brief. I'll allow Valerie plenty of opportunity to opine on this too, because the expertise there is outstanding. But listen, what you see in that last slide that I was presenting is, what are the exceptions actually? Are these, if you fit under this umbrella that I've demonstrated, are you just going to walk away as a clinician and just say, luckily I'm not liable under any circumstance? No, there's real exceptions to that. What you talk about, Doug, in relation to those sort of really egregious malpractice situations, if a doctor even remotely approaches anything of criminal or wanton or willful misconduct, they're getting tagged with liability. But most doctors, of course, are never going to do that. We have seen some healthcare workers in this pandemic actually get caught with that. That, of course, leads to liability on other fronts and, of course, delicensure. But the reality is there are real limits, and there's often patient recompensation funds that's set up through PrEP Act and other specific measures to help insulate against leaving patients in the blind on that specific front. So valid point, but to be sure, some protections are out there.
Absolutely. And when I was looking at the various state protections and the laws that were being passed and the executive orders that were being promulgated, I really found that they sort of fit into three different buckets. And those buckets had different levels of protections depending on the circumstances. And you can see why certain states would have adopted certain protections. So in one bucket was those that immunized or offered legal protections for those who followed crisis standards of care, rules, or guidance. And so those are the ones where there was actually a crisis. If there was a crisis standard of care that was actually triggered, then following that protocol would immunize you. And again, we've only seen a very small handful of states that have actually triggered these CSCs to begin with. So we're talking about a very small minority of places where this would even happen. The second category were those that immunized folks that provided care to COVID-19 patients. And that obviously excludes all of those other patients who are not being able to access care because institutions are being overrun where the resources are limited. And the third category are those that the broadest category, those that provide care in support of the state's response. And that's states like, I believe, Florida and those the states that we've been talking about. That's incredibly broad. That can be interpreted in an incredibly broad way. And you can imagine in those types of circumstances, that's when sort of folks start to fall through the cracks. And especially when those protections are being extended to healthcare institutions or nursing homes and long-term care facilities, that's where we're really seeing that these protections might be the last kind of level of protection in place that are now being pulled back. And so that's one of the other places that I have major concerns about.
I want to ask everyone from both a medical and legal perspective, what you all think about some of the data that has come in during the pandemic about the great amount of heterogeneity that has existed across the country with regard to protocols around crisis standards of care implemented at the local level. And some hospitals don't really even have any, for COVID. And what that means for at the, hyperlocal level within communities, what that means for physicians, and as they're trying to make decisions about what's best for their patient. Well, I'm at this hospital, but I saw this paper being released, or this, tertiary academic hospital is doing it this way, or there's this state policy, and I really like Doug White's, like how are we perceiving all of these different kinds of plans, and the legal ramification for adhering to or having coverage when there's so much heterogeneity? What is happening currently? You guys see going forward?
So Monica, I'll jump in with a quick observation and then look forward to additional colleagues on this specific question, because what and how the pandemic impacts specific jurisdictions, specific hospitals, even hospitals in the same region, differs that much in short order. And actually, just to note, the legal triggers for how you actually sort of engage or implement crisis standard care has changed during the course of this specific pandemic. It's that big and it's that impactful across those realms. But the antithesis of crisis standard of care, especially with the sort of recommendation we made all along to actually engage in systematic, comprehensive state planning, the antithesis of that is to see 3 hospitals in one city doing crisis standard care completely differently, even against the backdrop of the same sort of patient surges and scarcity. That's problematic, and there are ways to fix that. Some states are actually working towards that as we speak.
Dr. Peak, I might add to that discussion. I want to go back and comment a little bit about Professor Hodges' comments that providers feel safer participating in it with those liability protections. And Alaska, again, was unique in that nothing was in the statutes or in the regulations related to crisis standards of care and required an addendum to a House bill that was passed related to public health emergency in order to enact some degree of liability protections related to that. But what you comment on, the wide variance in Anchorage are the 3 hospitals that have the primary critical care services. As Alaska Native Medical Center serves 27 other tribal health organizations across the state, over 200 village clinics. 25% of those villages don't have running water or sanitation. So COVID was a huge impact in rural communities in Alaska. And the challenge was that the hospitals with critical care services all had variability in how they were using contingency versus crisis standards of care. And I think that really highlights or creates issues related to equity, because on a legal standpoint, the state doesn't have a strong system to ensure consistency amongst the various hospitals with critical care. So then patients in rural communities who may need transfer in essentially don't get on the list for allocation of resources. We were at multiple times where all hospitals with critical care services were closed. That meant the hospitals, if you were off the road system and could not show up by ambulance, transfers were being denied. In those areas, I think there was a reluctance without kind of a standardized process between the facilities to push into crisis standards of care from contingency, which in my mind would have been appropriate. Is the patient should move in from a rural area, and the facility, whichever was at the same level, should accept that patient and push from contingency to crisis. So those individuals, particularly Alaska Native individuals who have a significant disproportional burden of COVID, get equitable treatment with those patients that may be on the road system and are primarily have a larger percentage of non-Alaska Natives. So I think that the challenges in not having consistent protocols really worsens the equity issues. And I think helping with that legal standpoint and the protections associated with it hopefully would help address a lot of the equity issues. But we saw cases where no one would accept the transfer from rural facilities. And so in those cases, they don't get triaged at the same level and kind of exacerbates equity issues.
Yeah, I would like to follow up on that. That for lack, I guess one way to describe that is failures in load balancing. Some hospitals are resorting to triage when other hospitals have available capacity. And this, as Dr. Anders said, this is I think a key area for intervention to promote equity and also to save lives, right? It makes no sense for one hospital to be denying life support to some patients when another hospital has resources nearby. Those are just entirely preventable deaths. But it's worse than that, in that the hospitals that are most likely to need to resort to triage first are the hospitals that are critical access hospitals and safety net hospitals that have the thinnest staffing and the smallest budgets. And those are the hospitals where disadvantaged populations are more likely to receive care: Black patients, Latinx patients, rural and poor communities. And so, there's been a huge focus, appropriately, on what particular triage criteria should there be when making pairwise selections between patients. But I'm concerned that there has not been nearly enough focus on legal interventions to promote load balancing. And I know Professor Hodge is very familiar with what's happened in Arizona, which I think in many ways is a model for executive orders to promote load balancing. But I would just want to flag that triage and legal protections around triage are clearly important, but also legal interventions to promote equitable load balancing are, in my view, probably much more potent equity and life-saving strategies.
Yeah, I'm with Doug in a brief comment, and then let's hear from Valerie for sure on that. But yeah, what Arizona Governor Doug Ducey did is basically issue an executive order telling hospitals, you're going to accept these patients. We're not going to deal with EMTALA issues. We're not going to worry about that. EMTALA's been waived enough. Accept the patients. Let's low level. Let's prevent us having to revisit crisis standard of care. That's your gold standard. And when that can be done, that's powerful.
I'm going to just throw a related question into the mix, which is about whether or not the crisis standards of care are too high, and aren't a lot of clinicians operating under contingency standards perhaps more vulnerable to liability, and are there procedural safeguards that need to be in place to create a more trustworthy process? And that sort of gray area of flow between the two still has relevance for this very conversation that we're having around load balance and structural inequities between smaller community hospitals and safety net hospitals and the larger hospitals that have more capacity. So I'll just wanted to toss that into the conversation that we're having.
Yeah, if I may, I think a lot of this is an argument in favor of states, jurisdictions triggering some form of hopefully equitably promulgated crisis standards of care early. I think that there's been a huge amount of politicalization around these crisis standards of care, and therefore reluctance by many of our leaders to, in fact, trigger them, or even in some states acknowledge that they even have them. And that has caused enormous amounts of inconsistency across institutions, and a lot of just folks feeling like there isn't that guidance. And so it's important to recognize that just because a state or a jurisdiction has triggered their crisis standard of care doesn't mean it actually has to be instituted in every single facility across the board at every moment. It's when resources demand that crisis standards of care be followed, then they can follow it because it's been triggered already. And I think that that's going to give a lot more confidence to providers than perhaps even these immunity protections would.
That's a great point, Valerie. That's what, originally was at the heart of CSC. Limited, scarce resources is the trigger. And what and how that actually provides the legal environment to do what you need to do. Yeah, declarations of emergency help a lot towards that specific front. But yes, there's a lot of movement on that. Post-COVID, I think that we've learned considerably how to refashion CSC based on that analysis. It's great stuff.
I'd like to add to that, just at our facility here in Anchorage, pre-COVID, we operated at 90% capacity and majority double occupancy rooms. So very space challenged pre-COVID. And once we worked through the logistics of getting an addendum that enabled crisis standards of care, I think our posture has been to get on the list, be authorized through the state. And I think it is I don't think most people understand both internally activating and being authorized through the state for crisis standards of care. I think is a posture. You don't necessarily have to implement or use those allocation of scarce resources, but when you're operating routinely in deep contingency levels of care, it's appropriate to do that. But it did take a lot of messaging to internally through our incident command structure that we were and we still are internally activated under crisis standards of care and authorized through the state of Alaska for crisis standards of care, but we're not applying them unless we need to. But I agree with the early activation, early state authorization from a liability protection standpoint when you're operating in deep contingency, so that you're postured appropriately when you need to implement a triage team or other decision making, which could occur if you're at that level in deep contingency at any moment.
Yeah, I would just add, I entirely agree. I think pairing deep contingency and sort of the authorization of crisis standards of care with a prerequisite that there has been load balancing beforehand, because again, that concern that the safety net hospitals in New York City were splitting dialysis machines and pairing off patients on one ventilator, and that was called contingency care, even though there were hospitals nearby that didn't have anything like those resource scarcities. I mean, I really think that there needs to be a pairing of decisions about going into crisis standard of care with a precondition that all efforts at load balancing have been exhausted, including, parenthetically, and this is harder, but canceling elective surgeries and really quantifying, what are the things that we can delay for a while to free up ICU beds, even if there may be some harms from some patients that come from that.
It's a great point, Doug. And I would just highlight, what New Mexico did just recently, redeclaring CSC, not based on delusions of COVID patients, but delusions of patients that got put off for the last year. That's the new crisis in New Mexico, and they're going to manage it quite well. But the CSC declaration or trigger helps quite a bit on that front. We're
seeing that in Chicago as well.
Yeah.
I'm going to take us in a different direction for a bit. We had a question that came in from the audience, and it's this. I'll just read it. USA Today recently reported roughly 10,000 patients were infected with COVID-19 at the hospital when they came in for another reason, and many of those people died. The article points to a lack of hospital administrators' implementation of airborne precautions and placing COVID patients with non-COVID patients in the same room, lack of infection control, and staph infections, not STAPH, but STAFF, among additional issues. Are the legal issues with hospital decisions addressed here with crisis standards of care? Also issues of corrosive moral injury of nurses and doctors and gag orders. So I'll just toss that out to the group.
I'll be glad to field an initial response. And I do so against the backdrop that I don't have any confirmation of whether that USA Today story proves accurate or not, but I will at least say, and I'm not contesting what the reporters mentioned, as much as let's see what really comes out of this pandemic and actually, the sort of assessment, the hot wash assessment post-pandemic. Here's a simple reality. Listen, among all the entities that might be seeking liability protection in the throes of an emergency, hospitals as entities are among the fewest that are going to get them. There's a few states and the PrEP Act that actually may view those entities as sufficient for the purposes of garnering liability protection, but they're at the low end of that. Why? Because of some of what you're seeing there. If you failed to plan, if you failed to execute, and you've done things that actually just could have prevented these injuries but didn't, there your liability is getting to the close, you're getting close to that lack of protection for obvious reasons. So without further ado, to be sure, they're potentially going to have some liability to face.
And I think that's true even in the absence of immunity protections or immunity rules. The standard of care legally, and this is actually also an argument that's often presented in favor of not having these special immunity protections because they're unnecessary, is that the standard of care is inherently flexible. It's intended to adapt to current medical circumstances. And so in circumstances where resources are scarce or we don't know enough yet about the current circumstances of the pandemic or whatever it might be, that means that the standard of care itself is going to shift. And so these tort claims and these types of claims that we're going to see are going to kind of change with them, and we're going to see that that adapt as well.
Just one comment related to that. I think, like was stated already, if you adapt your standards of care based on the current environment, and in our facility, knowing that we had semi-private rooms, we were testing all inpatients every 3 days because that it's a risk we couldn't prevent based on our resources available, but we feel like we did and implemented the protections that were needed in order to do that, or because our PACU is crowded, so the post-operative area requires cohorting of patients, that everyone pre-op got tested as well, and that prior to requiring vaccination for all employees, that routine testing of employees. So I think I'm less concerned about the liability protections coming under crisis standards of care. It's more about what we implemented as protection measures, knowing what the risk was, and escalated that based on the environment of care.
So at the University of Chicago, we're doing universal testing for all the patients that come in. Is that what everyone is doing at their hospital systems also? Yeah, okay. We have 3 minutes left, so we're not going to get a chance to address this, but I just want you all to know that this has been tossed out. Can the panelists talk about the use of COVID-19 vaccination in triage protocols?
That's a hot issue.
Yeah,
it is.
But you know what? I just came off service in an ICU, so this morning actually, let me share with you some perspectives on that, and because I think there's a really important distinction to be made from our quick emotional impulse that this is a good idea, from a more considered judgment, and maybe a story might explain it. So I was caring for a young woman who's clearly dying of COVID, and she did not get vaccinated. Her parents did. They tried to get her to get vaccinated. She is an underrepresented or a disadvantaged minority. And when we talked about why she did not, they said, well, she believed from Facebook that there were baby parts in the vaccine. And so this is an example where, in a pure analytical sense, if people are making truly informed choices not to get vaccinated, in a true ideal circumstances world, maybe this is permissible to consider. But when we have a toxic political discourse that is really leading people to make decisions that, are probably profoundly impacted by distrust of the health system and poor health literacy, I have grave concerns about using vaccination status as a triage criterion.
Excellent story. Very powerfully put. And maybe we'll wrap it there. We have a 10-minute break. And so we'll plan to meet back at the top of the hour. So thank you so much to all of our panelists. This was really fun and insightful. I hope the audience enjoyed it as well. We did not get out to all the questions. But, there it is. So thank you again, James Hodges, Robert Anders, Valerie Gutman-Cook, and Douglas White, for all of your insights, sharing your time during the pandemic and coming off service. And we'll see everyone back in 10 minutes.